Good evening, everyone. I am honored to introduce Dr. Vishwanath S, consultant medical oncologist. He is an accomplished medical oncologist with a fellowship from the University of Texas. He has MD from Anderson Cancer Center in Houston, USA. He has an outstanding academic record with gold medals in DM Medical Oncology from Kidwai Memorial Institute of Oncology and in his MD Internal Medicine from Kasturba Medical College. He has published widely in journals with high impact factors and has over 40 international publications. He has won several prestigious awards, including an Abstract Achievement Award from the American Society of Hematology. Dr. Vishwanath has a unique art of taking his understanding of the molecular nature of cancer to the bedside and giving personalized cancer care to his patients. His compassion, empathy, and approachability to his patients make him a sought medical oncologist. Welcome you, sir.
Upashri, for that intro. Uh, in fact, I would like to start with saying, one of my friends, IT friend in my apartment complex, asked me, Doc, do you work on Saturdays? I said, yes. Do you work on Saturday evenings? Yes. Sunday mornings, yes, I have to go for rounds. And what about Sunday evenings? That's probably the only family time or FT which we have. And it's such a pleasant, it's so nice to see all of you in such large numbers. And thank you so much, Family Physicians Association of Bangalore, for giving me this opportunity. And it's my first time here, and I'm really enjoying it. So switching gears, after my two wonderful women colleagues in the department talked about the women cancer. So it's about lung cancer, not common, not exclusive to men, but it's becoming very common in women too. So, okay. So I'm going to run through the basics of lung cancer, which most of us already know, and maybe a few points which are uh, kind of revolutionize the treatment. What's happening? Okay. So lung cancer is a malignant tumor characterized by uncontrolled cell growth in the tissues of the lung. If left untreated, we all know that the growth can spread beyond the lungs by a process what is called as secondaries or metastasis into nearby tissues or other parts of the body. Okay. So how common is lung cancer? Lung cancer is actually very common. This is the GloboCan, which is the worldwide incidence of lung cancer. And as you can see here, lung cancer in men and women is quite common. It's amongst the commonest cancers in the world. And not only that, look at the death rate. The death rate is also quite high, and it's around 18% of all the cancers worldwide. And what about India? So if you look at men, it's one of the leading causes. Actually, it comes second. And not only in men, even in women, it's actually catching up, and it's also catching up in non-smokers. So you can see that the incidence is quite high, the mortality is also quite high, and we do know that we are facing challenges with this diagnosis and treatment. And look at this, the top 5 cancers in men, it's the lip and oral cavity followed by lung. And look at women, it's breast, oral cavity, cervix, and then you have lung. So lung is quite common even in women. And look at this, the Asians are quite prone to lung cancer, and as you can see in this cartoon, that lung cancer is quite common in Asians, both men and women. So this is broadly about the classification of lung cancer. We do know that there is something called non-small cell, which is 85 to 90% of the cases, and small cell. Small cell is exclusive to smokers, and fortunately, since it has a very poor prognosis, is seen in only 10 to 15% of the patients. And non-small cell, again, depending on what you see under the microscope, can be squamous or non-squamous, and non-squamous again has two types. It's got a large cell carcinoma and adenocarcinoma. Of course, the classification is more comprehensive than what is shown here. This is a simplified classification. And the risk factors, of course, the single one important factor since the time we have known about lung cancer has been smoking. Smoking, both the smoked tobacco, smokeless tobacco, and there's also something called second-hand smoke. What is second-hand smoke? Passive smoking. And there is also something called third-hand smoke. Somebody comes to your room or office, smokes, goes out. It's all, the carcinogens are all in the furniture and in the room, and you inhale that, and that's full of carcinogens. So third-hand smoke, second-hand smoke, third-hand smoke, all this is quite important for lung cancer. And not only that, your genetics, of course, they do play a role. It's a non-modifiable factor. You can't do much about it. Aging. So if an 80-year-old or 90-year-old male or female, you need to die out of something, you get lung cancer, that's different. But we are talking about younger people getting lung cancers. And then asbestos, arsenic, radon. So many of us don't know that radon is actually, the radon gas is quite, it's there in all our rooms, and we need to use something called air filters which can also purify radon. Radon exposure over a long time can lead to lung cancer. And chronic obstructive pulmonary disease and interstitial lung disease, the chronic airway diseases, can all be a precursor for lung cancer. And this is the different carcinogens. We all know that more than 1,000, it's actually 3,000. Certain books say that it's around 3,000 carcinogens which are there in the cigarette smoke. And I told about this, the active, passive, and third-hand smoke. And 90% of the lung cancers are attributable to smoking, but things are changing now. And only 20% of smokers do develop lung cancers. So that's a question which is always asked by our patients. We have so many of them who are smoking, but not everyone develops lung cancer. Why? There is something called passenger mutation and a driver mutation. It can be just a passenger, it can be just dormant in your body, and you may still not develop lung cancer even if you're smoking like 20 packs a day, or even 5 packs, 20 packs, whatever, for several years. But if you have if there is a driver mutation, that can drive and you can develop lung cancer. So again, the risk does not become zero with smoking. That's very important. Even reform smokers can develop lung cancer. And 50% of new cases are actually former smokers. Yes, it's important to abstain, but the single most important thing is don't smoke. And look at the odds ratio. You can see that non-smokers it's 7, but you can also see that ex-smokers it's 2 to 10. So it does mean that even if you abstain, if you stop, there is always a risk of developing lung cancer. 15 to 20% of men with lung cancer are non-smokers, and 50% of women with lung cancer are non-smokers. Of course, it's very difficult to get the exact data on how many of them are actually passive smokers. I think all of us are actually passive smokers if you look at that. And 60 to 80% of lung cancer occurs in non-smoking women. So this is a data from Tata Memorial, not too old, but it's from 2012. And I'm sure the data is getting generated more. And 52.1% are non-smokers, and 41.8% actually occurs in men who have never smoked, and 88% in women who have never smoked. So this is the very alarming situation which we have to do something about. And coming to the symptoms, we do know these common symptoms like persistent cough, shortness of breath, hemoptysis, unexplained weight loss, repeated respiratory infections, non-resolving pneumonias, and of course something related to metastasis, like if it goes to the bones, you might end up with a fracture. If it goes to the brain, you might develop seizures, headache, vomiting, so on and so forth. So, of course, like the previous speakers did mention, Dr. Jayanti did mention, and Dr. Rani Bhatt also, that early diagnosis of any cancer is the most important thing. And in India, one of the masqueraders is tuberculosis. Time and again, we see that tuberculosis is being diagnosed, and instead the patient may have actually harbored a lung cancer. So it's always a masquerader. And the best way to diagnose lung cancer is to catch it early, even before it produces symptoms. I'm going to come to the screening part. And diagnosis in late stage was pretty bad, but things are getting better and better with so much of targeted therapies and immunotherapies. So coming to the tests, how do you diagnose? We have the simple chest X-ray, but chest X-ray does not pick up lung cancer in all situations. And then we have CT scan, And we have PET scan. Nowadays, PET scan has become like a one-stop investigation for all cancers, in fact. So PET scan basically goes on the basis of this injecting something called fluorodeoxyglucose, which is an isotope. It's a glucose type of isotope. And then you inject that, and then whichever disease, wherever there is disease and it is active, it takes up that particular FDG, and that can appear as a different color. I'm going to come to that, how it actually appears. And that way you can also know where the disease is, how active it is, and especially for exactly targeting and going ahead with the biopsy, it helps. And not only that, your patients are going to come and ask you, okay, if you've received 4 cycles, doctor, you've given me 4 cycles of chemotherapy, how much is the disease, how is the response to the disease? So for multiple factors, PET scan has become like a one-stop investigation. And then bronchoscopy, in fact, in Apollo Hospitals, Bangalore, we have a wonderful advanced pulmonology unit which actually looks at, they've specialized in this interventional pulmonology, and they do EBUS, which is an endobronchial ultrasound, to pick up those early stage lung cancers. Not only that, we get excellent samples with EBUS, with especially those centrally located tumors where you cannot go in with a CT guided biopsy. You want a chunk of tissue to do this molecular analysis. We have those experts at Apollo Hospitals, Banagatta Road. And then this is the PET CT which I was talking about. Wherever there is disease, it actually appears it appears yellow, and you can also go ahead with the targeted biopsy or PET CT guided biopsy or a CT guided biopsy for that particular lesion. And I was talking about this EBUS, which can help with staging and also diagnosis. Treatment has significantly evolved in lung cancer. Lung cancer previously, probably in the 1980s and 90s, was a dismal disease. In fact, patients it was considered like a death sentence, 6 to 9 months of survival. But now, depending on the stage, you have a multimodality treatment. Early stage, you do surgery plus or minus chemotherapy. Stage 2, again surgery plus or minus chemo. For stage 3, you give a combination of chemotherapy and radiation, and patients live long. And then for stage 4, nowadays, it's become what is called as personalized medicine. What is personalized medicine? It's unique to that particular patient. You give the right treatment to the right patient, to the right disease. So what do? Like I was talking about, get the tissue. In the tissue, you do some specific molecular tests or mutation to look for specific mutations. For example, there's something called EGFR, epidermal growth factor receptor. This particular mutation is very common in females, non-smokers, and Asians. So, an Indian woman walking to you with lung cancer, stage 4, there is 80% chance that she would harbor this EGFR mutation. And what is the importance? With just a drug for 3,000 rupees a month, 30 tablets with our wonderful generics. Initially, when it came into the market, the innovator molecule, it was 100,000 rupees per month. It's come down to 3,000 rupees a month. Why? It's all because of our made in India, the biosimilars, or what we call as generics. With this, the patients are living 3 to 4 years, 5 years, certain times 6 years, with just a simple tablet, very minimal side effects, probably just skin rash and diarrhea. This is the wonder. I would say the targeted therapy has significantly revolutionized. It's not only about EGFR, we have several other mutations which we analyze. That's the important. Tissue is the gold standard. Tissue is the issue. We always need the tissue. We can't do it on FNAC. So it's very important that we get a good tissue so that we can do all these molecular analysis. And here is the importance of multidisciplinary tumor board. In fact, whenever there's a breast cancer or ovarian cancer, we always discuss a peer-to-peer discussion. Dr. Jayanti, I, and the radiologists and the pathologists, we all sit together. Most of the times we've seen Sachin Tendulkar scoring a century, but India will end up on the losing side. Why does that happen? So it's only because the other people have not contributed. So it's very important that a medical oncologist, radiation oncologist, the pathologist, radiologist, and the pulmonologist in case of lung cancer, we all sit together, make the right decision making for the patient. And this is the importance of multidisciplinary tumor board. And I talked about the treatment, which is summarized here. And I also told about the targeted therapy. Main advantage is it doesn't kill the normal cells where patients are really worried about, and the WBC counts going down, the platelets going down, and are getting admitted in the ICU with fever and neutropenia. All this doesn't happen with targeted therapies. That's the importance of targeted therapy. I also told about this personalized medicine. So by doing this, there's so much of molecular landscape which has kind of come up, and we have understood the genomic landscape of this disease so well. It's not only about lung cancer, for several other cancers, that we are able to treat patients better and with the right treatment. So these are all the different mutations which can come up when you do a genomic landscape with what we call as next generation sequencing. We analyze the RNA and DNA of the tissue, and we get so many mutations. And depending on the mutations, you have a target. That's the beauty. So the next question is, can lung cancer be screened? So the question is, are you eligible? So if you are between 55 and 80, and if you have been smoking 1 pack a day for the last 20 years, or if you have recently quit in the last 50, I would say in the last 15 years, if you have not exactly recently, but it's last 15 years if you have quit, and before that if you have been smoking quite a lot, then you are eligible for getting what is called as a low dose CT scan, which is 1/10 the radiation of a HRCT or a normal CT scan. So that way, if you can do it annually, you can pick up small lesions, early disease, and definitely early disease with surgery, plus or minus chemo or targeted therapies, patients can definitely even end up being cured. That's the importance of low-dose CT scan. This was actually one of my articles which got published in Indian Express. In fact, Dr. Jayanti was saying, why don't you talk something about COVID? Very interesting. So, in fact, we had a couple of patients who came to us, and one was a 69-year-old lady who actually had COVID, very bad COVID, and then CT scan was done actually for COVID. And then during the CT scan, apart from the COVID pneumonitis, we also picked up this early stage lung cancer, and she's done really well with this with treatment. And similarly, we had a 74-year-old gentleman who came in, again COVID. He came from Raichur, and then he was very happy that actually his lung cancer got picked up pretty early. And that gentleman, it's been now it's almost more than a year and a half, and he's been doing well. So so if you look at COVID and lung cancer, I was actually Googling this afternoon the American task force. In fact, things are quite different there. They are saying that the number of patients, number of individuals who got screened for lung cancer has come down. Hence, COVID has had a negative impact. In fact, I am putting forward the positive impact. The number of people in India who are actually going to get a low-dose CT scan, even the smokers, are going to be very minimal. So I don't think many of us are even aware that lung cancer can be screened with a low-dose CT scan. It's just coming up. So I wanted to emphasize the positive aspect that, in fact, COVID has picked up. It was a blessing in disguise for several patients who had COVID, and we could pick up lung cancer early, and they've actually done well. So coming to the prevention, I think quitting smoking is the single most important thing. It's easily said than done. And avoid second-hand smoke, third-hand smoke, avoid exposure. It's all, I can just go on and on. I think it's also about policy making and several other things. I think charity also starts from home. We have to probably use our cars which are less polluted and get our pollution checkups done. Several things. It just goes on and on. And then primary prevention, it also boils down to what you eat. Eat healthy, vegetables and a lot of antioxidants, which has a lot of antioxidants, fruits, which has got a lot of vitamin A, vitamin E, selenium, vitamin C. So again, this is something which is very important. And secondary prevention, early diagnosis, like I said, chest x-rays, low-dose CT scans, and only those high-risk individuals, not everyone, not because the radiation exposure, the risk-benefit ratio, only for individuals who have smoked for at least 20 years and who are over 50 years of age, it's actually applicable. And sputum cytology, not very often used these days, but yes, it was used, and several times we have actually picked up. And tertiary prevention, again, patients who have been diagnosed and who have survived, assist them. It's very important. Survivorship is an important aspect of our care. And thank you so much for a patient listening, and I think it's important for smokers to stop smoking. And thank you. Thank you.